Welcome again. Thanks for wake up with us this Friday's meeting. Today we have a great honor. I can introduce you Dr. Luigi Dall'Oglio. He's a friend of our service, one of referent consultants of difficult case of many pathologies, but in this occasion, in this opportunity, he's a referent consultant of management of patients with esophageal atresia. So Dr. Luigi Dall'Oglio is a chief of surgery and endoscopic digestive service of Ospedale Bambino Gesù in Roma, Italia. So Ignacio, we can start with presentation.
Okay, please, Ale, can you put the next one? Okay, the exposing team coordinator is Dr. Urquizo, who is one of our staff members, along with Alejandra Curiel, Sabrina Pintos, and myself, Ignacio Arenas. We will begin our exposition with a clinical case. So it is a patient who is 1 month old. He was born after a full-term pregnancy with no history of obstetric complications. He was born with normal weight in Tucumán, in another state from Argentina. The postnatal diagnosis of EA was made in the ICU, and during the first day of life, he was operated. 6 days later, he started enteral feeding through a nasogastric tube. At the 10th day after surgery, he had a cardiorespiratory arrest. So after this acute intercurrence, they started to do many exams. One of those were contrast X-rays, which shows esophageal anastomotic stricture. With these complications, the next one, you can see there in the right side of the image, the two studies where you can see the anastomotic stricture. So with this complication, they realized 2 dilatations with buoys separated by 1 week with not so good results. With this situation, so there you can see the video. Please, the next one. So with this situation, they referred the patient to our hospital. When he arrived, we made a new esophagogram who showed an anastomotic stricture. So together with the pediatric gastroenterologist, we did an upper endoscopy where we saw a severe stenosis. So in that moment, we decided to dilatate up to 10 atmospheres with a balloon of 6, 7, and 8 millimeters. 1 week later, we repeated the same procedure, and we dilated until 10 millimeters with 8 atmospheres. After that, yes, in that one. So after that, we control the anastomosis. You can see there the right image. We didn't have a leak, but as you can see, it has difference like pouch between the anastomosis. Another week later, we realized a new X-ray esophagogram where you can see again this problem that we have shown before. So currently, we have a patient with normal gaining weight receiving enteral feeding, all by suction, and receiving anti-reflux treatment. So now, after commenting our clinical case, we are going to start with the literature review. First of all, we are going to talk about a complementary paper was published, the next one, who was published on Sociedad Española de Cirugía Pediátrica Journal on 2020. The objective of this paper was to evaluate the anastomotic stricture index as a predictor of the need of future dilatation in the esophagus after these surgeries. The research was done from 2009 until 2017 with a total number of patients, 31. About the method, it was a retrospective study, and the rules of it were to make 2 esophagograms. The first one carried out on the first week post-operative days to reel the anastomotic descents and where the patients start enteral feeding. And the second one was performed during the follow-up of the patients. The next one, please. Yes. So the index, as you can see there, shows the relationship between the pouch and the stricture diameters, and the results were. This is the next one. Was the study median up of 4.1 years. 21 patients, 67% were diagnosed with AS, this stricture requiring 1 esophageal dilatation, and at least 11 of them, the other 35%, had recurrent strictures requiring median of 6 esophageal dilatations. As in the first image, wasn't statistically significant between ones who didn't need a dilatation. So the other one, please. This image shows the index who goes from 0 to 1, where the number, when the number is closer to 1, the risk of recurrent stenosis and need of dilatation is higher. And in the other side, if the number is closer to 0, no dilatations were required. So in conclusion, there is a correlation between the proximal index and the second esophagogram. It is an important tool to identify risk of requiring future dilatations.
Well, as we said before, the main article that we will talk about today is titled An International Survey on Anastomotic Stricture Management After Esophageal Atresia Repair, Consideration and Advisory Statements. This article was presented in the Endoscopic Surgery Journal in 2020, and Dr. Luigi Dall'Oglio was the main author. Up to 60% of children with esophageal atresia develop an anastomotic stricture after surgical correction, mostly in the first year of life. Based on a recent guideline for the management of complication in children with EA, the first-line treatment for anastomotic stricture is endoscopic dilatation. The primary goals of esophageal dilatation are symptom relief, maintenance of age-appropriate oral nutrition, and reduction of pulmonary aspiration risk. But there is no consensus on how dilatation should be performed. 2 different methods are used: semi-region dilatation or balloon dilatation. Balloon dilatation applies a radial force over the entire length of the esophageal structure, while boogie generates gearing axial forces as they pass across the stenosis as seen in the image. Due to the lack of strong evidence, the choice of dilatation method is currently based on the center's and operator experience and preference. Next, please. Okay. A cross-sectional survey study was conducted from November 2018 up to and including March 2019. A free access online questionnaire consisting of 38 questions in the English language and was distributed via email and newsletters. Participants could be of any specialty as long as they had experience in the treatment of anastomotic stricture in children with EA. Next, please. The study question included the number of dilatation procedures performed in the center per month, the preferred dilatation technique, balloon dilatation or Vlot, and the use of alternative Warshut band treatment option for recurrent strictures. Descriptive statistics were applied to the data. Data are represented as number. And the aim of the study is to provide an overview on differences in endoscopic dilatation treatment of pediatric anastomotic stricture worldwide.
Well, about the results, they are divided into 5 categories. According to response, number 1, 202 questionnaires were complete with the participation of 32 countries. After excluding the incomplete submission, 115 centers remaining for analysis. As shown in the figure, the questionnaires answered mostly by gastroenterologists and pediatric surgeons, and 2 listeners by gastroenterologists and general surgeons. Well, as for doctors who perform endoscopies, response came from 32 countries worldwide, and 60% the participating European centers, and 50% the participating South America. The majority of the centers perform 10 and 30 pediatric endoscopies per month. 29% of patients with EA less 18 years under follow-up, and 52% of dilatation procedures for anastomosis strictures in patients with EA 4 months. Endoscopies were most frequently performed by pediatric gastroenterologists and pediatric surgeons versus adult gastroenterologists. Well, regarding the approach to anastomotic strictures, 68% centers dilation only in symptomatic patients. 31% centers routine dilatation were performed to prevent symptoms to occur. This visual shows the mostly used technique to measure esophageal anastomotic stricture in patients with esophageal atresia. Being balloon dilatation, the most used technique in the survey centers. Well, the balloon and semi-radial dilatation, every center uses different dilatation techniques. They are shown in the images. However, some centers stood as of reference, age of the patient, or races and the moment of dilatation or situation. The recurrent and refractory strictures, well, the different options described in this article for recurrent and refractory stenosis are local injection with steroids or topical mitomycin application or anti-reflux medication or fundoplication surgery or recession with a new anastomosis or injection of the vitamin B. As the conclusion of the article, they found a large variation in strictures management in children with A, which confirms the current lack of consequence. International networks for race disease are required for harmonizing and comparing the procedures, for which we give several suggestions. In this image are the recommendations for the management of anastomotic strictures in patients with esophageal atresia. The limitation were the absence of a response rate could potentially lead to a bias in the results. And they excluding almost half of the responses because they were incomplete or pending, which maybe have led to selection bias. Also, the responses covered cis continents, Asia and Africa were less represented. Thank you so much. Welcome from our special guest and final comments with Dr. Urquizo.
Thank you. Thank you, Ale, Ignacio, and Sabrina for your presentation. As you know, the anastomosis stricture is a frequent problem. Sometimes we think that it doesn't, but if we review the international reports, the incidence of the stricture of the anastomosis can be up to 70%. What do you think about, Dr. Luigi, about the frequency of high incidence of the anastomotic stricture during the esophageal atresia repair?
Can you hear me?
Yes.
In our experience, we observe high incidence of anastomotic strictures, but our hospital have a very special situation because it's a third level hospital, a referral hospital for very difficult cases, and so we observe often patients that come from our from other centers with long gap esophageal atresia. And we know that the distance between the two pouches of the esophagus allow a high incidence of anastomotic leak and so anastomotic but we have some cases that didn't perform dilations during the life, but they are very rare.
Okay. Yes, the long gap definitely is a different chapter of a patient with esophageal atresia. It's require different skills and different view of points to repair, and I'm agree with that. I know that you are on your treatment these patients long time ago. How do you see the evolution of bougies and balloon?
In our experience, we prefer to use bougie. We use Savary dilators. This is because not only in our experience, but also in the experience of in the literature, there is not a higher incidence of complications in Savary than in balloon. And in our experience also, we can manage the dilations not only with the interface of a manometer, but we can, with our hands, we can force the dilator, and so we can avoid the risk, we can reduce, not avoid, we can reduce the risk of perforations with the dilations, because with every operator with his own own experience can calibrate better than the balloon how much he can force the stricture. And also the third point, that we can reuse the Savary. Otherwise, the balloon are single use, and so the economic aspect is sometimes very important.
Definitely. Some people can think that, or young surgeons think that Bucci is a method to the older surgeon, and the older surgeon prefer the Bucci. But it's important to know that the experience have to learn the dilation is the most important. It's one of the recommendations of your article that this procedure was made for the most experienced physician, like a gastroenterologist or surgeon, and in the tertiary referral center. One thing that I review on your paper was there's no consensus with which is the best diameter of the esophageal can we dilate. How do you think that is happening? How can I learn what is the best diameter can we get with the dilation in the different age of patients?
It is a very interesting aspect that we have to discuss. Renato Tambucci, that is my colleague that follow the multi-center study in about balloon or Savary dilations, wrote another paper about the problem of the 3 times measure to calibrate the anastomosis. That is an old rule, but in our experience, it is not not so clear. In our experience, we dilate. First of all, we pass the guide wire, and so we have an idea about the diameter. Then we start with the thinner Savary, and we observe when, after the passage of the Savary, we can observe a damage of the esophageal mucosa. So this is the first dilation. If we pass the 5 millimeter Savary and then the 6 millimeter Savary without damage, we can say that the anastomosis, the stricture is more than 6 millimeters of diameter. Then we start with the dilations, and we don't go over 3 times the diameter. So if we have a patient with 7 millimeters diameter, we don't go over 9 or 10 millimeters of dilations. It depends also of the age of the patients and what he needs to eat. Because if the patient eats only milk, we can have a good caliber with 7 millimeters without problems. Otherwise, if the patient needs to eat normal food, obviously we have to go on with 1 dilation or with 2 two times dilation, in 2 different days.
Yes. Even the milk or what kind of food is the baby eating, it's important. So in our case that we present, the baby has 2 months, and the initial stenosis was the 6 millimeters, and the baby can drink the milk. You need an OG tube to nutrition. So I can think that it's another factor that's included, like a dysmotility in the esophageal atresia. So the dilation we can get with this patient go to the 10 millimeters. It's a baby of 2 months, and it's so much 10 millimeters. But to this diameter, the baby can drink the milk. Maybe he coughed, a very severe cough, a tracheomalacia cough, but the baby drinks the milk and don't need the OG tube to feed him. So, like Dr. Luigi Dall'Oglio said, there are many factors, and includes that what kind of food the baby needs. Pablo?
Thank you, Mauricio. Good morning, everybody. Thank you, Luigi, for being here. It's always a pleasure to share with you our cases. And I have 2 questions for Luigi. First one is, which is the lowest age that you have performed an esophageal dilatation on a patient with esophageal atresia? For example, this case, our case, was a very young patient who was referred at less than 1 month of age, and he had at the initial center 2 dilatations with rigid boogies. They were done with urethral dilatators, so not so effective. But I think that the first dilation was performed at about 10 days or 2 weeks after birth. So how young do you think that is it safe to perform an esophageal dilatation after the correction of the esophageal atresia?
I think that after an anastomosis, without a leak, obviously, a good anastomosis, if the patient has a stricture, I think that with an important stricture that involve the problem of aspiration of secretion, obviously of food, I think that it's important to perform one dilation when it is necessary. After 15 days, it depends. But it's important not only to dilate, but to avoid the relapse of the stricture. It is really the most important aspect of this job. And in our cases, we overall, when the patient is very young, very young, less than 1 month, we leave in place a silicone tube. We use flow care that are 12 French in diameter, but also 8 French. So the milk and the secretion can pass around the tube in the space between the esophageal wall and the tube, something like the dynamic stent, Pablo, but something that is before, and it's very helpful to avoid the need for the patient to perform another dilation after a few days, because sometimes the stricture, as you well know, are very difficult to avoid the relapse. And so inserting a tube is very helpful. Also, we use sometimes the Blake surgical drainage We cut the not tubular part of the blade, and we insert, because we can insert a tube that is 15 or 19 French. So very, very large tube, but soft, silicone. The patients can stay with the tube in place without special discomfort, and so we can obtain the stabilization of the stricture, avoiding a very quick relapse of the strictures. And in our experience also, the use of viscose budesonide also, I think that can represent an important adjuvant treatment for these patients.
Interesting. So do you use budesonide in which cases? In recurrent stenosis, or in every case in small babies?
No, only recurrent stenosis.
Okay. And could you make a comment about gastroesophageal reflux? Because you know, it's always the question about is the reflux responsible for the recurrence of the stenosis? And also, if you put a tube inside, so someone said, okay, the esophagogastric junction will be open by the tube, so reflux will be worse. What is the current guidelines for the treatment of reflux in these patients?
When we wrote the international guide wire, Asperger, we suggest in a statement the use of PPI in the first year of life, and so we can reduce the negative impact of acid gastroesophageal reflux. But we, in many of our cases, we observed a very, very special situation, performing with routine the pH impedensometry, that the problem sometimes is not a problem of gastroesophageal reflux, but a problem of distal esophageal dysmotility, severe. And the problem is not the reflux, but on the contrary, that the secretion and food remain in the distal esophagus, and this problem can damage the esophageal mucosa. And in these cases, probably performing an anti-reflux surgery not only help the patient, but improve the discomfort of this motility and the problems. So we avoid to perform surgical fundoplication before the first year of life, because we have the opportunity to treat these patients with PPI without problems. Obviously, there is the difference of respiratory problems with demonstration of aspiration. This is obviously something completely different problem, and so it becomes mandatory to perform a fundoplication in these patients. But before to perform the surgery, we have to evaluate correctly the motility of the esophagus, and to rule out the presence of stasis of secretion in the esophagus. So sometimes it's very, very difficult to manage these patients, because there is a problem of acidity, but not only from reflux, but also from other problems. So we observed many patients surgically treated before the first year of life with severe problem of nutrition, because of the problem of esophageal dysmotility.
Great.
Great. We have one question of Dr. Mauricio Figueroa. He asked, in case with leakage of the anastomosis and posterior evolution to severe stenosis, when do you recommend begin the dilation?
We start with the dilations when we are sure of that the leak is closed, and when the patient needs the dilation because has a severe stricture, because we know that after a leak the stricture is more severe than a normal anastomotic stricture. And sometimes you can observe something like an esophageal, again an esophageal atresia with a complete occlusion of the esophageal lumen. So in these cases, it's very important to prevent the strictures with a tube in place. If you have something in place, even if only a suture from the nose to the gastrostomy, it's very, very important to have something into the esophageal lumen. Then we can dilate. But if you can treat the patients before with a silicone tube in the esophageal lumen, everything is very easier to treat. But after 15 days after the complete occlusion of a leakage, I think that it's possible to make a first very, very, very accurate dilation of the esophageal lumen if you need.
Okay, talking about active fistula of the leakage of the anastomosis, what do you think about esophageal vacuum, endoscopic esophageal vacuum in this case? What's your opinion? You are agree? You are waiting for more experience? What do you think about it?
I think that it's a very, very important and helpful device and strategy to treat complications. There is the paper of Michael Manfredi, the first who described this strategy, that shows an important improvement in the outcome of very complex situations. In our experience, we have good results also with the simple pharyngoesophageal suction with their plug, with a two-line aspiration tube, that sometimes we can insert into the leakage to drainage the mediastinum or pleural fluid collection. And then we can slowly pull back into the esophageal lumen, avoiding the insertion of a pleural trocar. It's important because if we insert a trocar, we have a pressure that allow the maintenance of the leak. Otherwise, if we avoid to drainage the pleura, obviously, if it's possible, it depends on the clinical condition of the patients, and we can insert the tube directly from the nose into the esophagus, then into the perforation.
Okay.
Perdimos.
Sí.
Interesante el concepto de drenar la colección mediastinal a través del esófago.
Sí, el artículo original al que se refería habla de guiar justo a través de la salida y colocar bien distal, a lo más distal posible, y poco a poco ir retirándolo, y uno logra en poco tiempo el cierre de esa pseudocavidad, y cuando uno llega al borde del esófago, como que se favorecería el cierre. Esa es la descripción del artículo original. Sí, después ha ido cambiando.
¿La sonda tiene que ir a través, Mauricio, al principio, por lo que
Sí,
vos decís?
atraviesa la perforación esofágica, la fístula, y uno deja la aspiración en la cavidad pleural.
Eso, igual él decía que lo hacen con el reproble directamente, no haciendo un vacuum formal, ¿no?
Lo importante es que lo hace con reproble.
Sí.
Lo importante es que lo hace con reproble.
Uh-huh.
El reproble es fundamental en esto. Tanto dentro del esófago, proximal a la fístula. Bueno, la fístula es una novedad, pero tiene que ser una fístula grande, que a veces no la ves tan bien. Nosotros lo hemos intentado una vez y no pudimos con votos.
Sí, lo que creo que la gran ventaja que ellos tienen es que ellos hacen todo el tiempo la endoscopía digestiva flexible, la hacen ellos, entonces pasan una bujía, sacan, ponen el endoscopio, miran, vuelven a sacar, vuelven a pasar otra bujía, y la ubicación de este tipo de dispositivos y demás lo hacen bajo guía endoscópica.
Y de hecho yo quería repreguntar, porque me interesó el concepto de parar de dilatar ante la lesión de la mucosa, cuando Mauricio le preguntó, ¿no?
Exactamente. Cada dilatación que hace, entra con el endoscopio y vean si la mucosa está lastimada o cómo está, y de eso, en base a eso regulan cuando paran de dilatar.
Ahora, ¿vos te das cuenta lo que implica no hacer la cirugía bien de entrada? Que estamos discutiendo una hora sobre las complicaciones. Es más importante hablar de la técnica quirúrgica para evitar esto. Estas fístulas se producen por dos motivos. Yo me enganché tarde por internet, pero se produce por dos motivos. Por destrucción de los bordes libres de los cabos esofágicos o por filtración de la anastomosis. Y si vos evitas esas dos cosas, vas a tener muchas menos complicaciones. Y obstrucción de la luz con un tubo pasado a través de la anastomosis, que aumenta la presión en el esófago proximal. Son pequeños detalles que hacen que reducir tu necesidad de dilatación posterior. Yo voy a buscar mis atresias de esófago de los últimos casos, a ver qué porcentaje de dilatación tuve que hacer, hablando de una como mínima. Es muy poco, si uno respeta el procedimiento quirúrgico, que no se juega la solución del paciente. No sé, no quería hablar yo.
No, pero es tal cual lo que usted dice. La incidencia de estenosis que uno ve en la bibliografía, este estudio tenía una incidencia de estenosis altísima, ¿no? De 60 y pico %, que es un montón.
Este cuestionario internacional que ellos hacen específicamente de anastomosis es una... Ok, we come back again.
Luigi is back.
We are talking about...
We lost you.
We're talking about how can prevent, or what can we do to prevent this big problem, which is the leakage, with the correct technical skills.
Luigi, Dr. Puigdeval was talking about preventing stenosis and leakage with some correct techniques or a correct technique at the initial esophageal atresia operation. What do you think about that? What do you think that the key factors that the surgeon performing an esophageal atresia initial surgery should take into account to prevent stenosis?
Obviously, reducing the tension between the two patches is the key of the sutures. And many different strategies were described in the last years. We don't have got good results with the Fokker technique, but is our experience in other centers, this strategy works very well. We prefer sometimes the Kimura strategy to obtain the elongation of the the upper pouch. We don't like also to pull the gastroesophageal junction into the thorax with something like the Charlie strategies, because after these strategies we can observe a severe gastroesophageal reflux with big problems for the patients. It's very difficult to answer to this question, because it's really the most important questions in all the surgical center that take care of patients with long gap esophageal atresia. Some surgeons prefer not to insert a nasogastric tube. Others say not. Others say yes. It's very difficult. There is not only one answer to these questions. To this question.
Yes, Dr. Curiel.
Hola. May I speak?
Yes, of course.
Hello, Dr. Luigi. How
Hello.
are you?
Fine, thank you very much.
Fine.
Nice to see you.
Fine. I'm leaving yet. Now, what I mentioned was more not the long separation of esophagus, but the small details of the technique you have to follow. First, I try to know the trypsia of the border of the section of the esophagus. That produces necrosis and posterior fibrosis. Second, what I try to do is to avoid the leakage of the anastomosis using too many sutures. Almost, I put at least 15 to 16 sutures in anastomosis. There, what I try to, I don't leave a trans-anastomotic tube, because this reduces the lumen, and this causes some kind of obstruction in the first days of post-surgery, and this increases the pressure in the anastomosis and filtration, which is cause also of fibrosis, perianastomosis, and stenosis. Third, I use repro aspiration in esophagus proximal to anastomosis for 4 or 5 days after the surgery, to avoid the pressure of secretion of saliva into the anastomosis. And I really reduce the number of patients with needed dilatation posteriorly. What I am in the that I have to do the numbers, because there's a subjective impression, but I have to do it. Do you follow me?
Yes, perfectly. I totally agree with all these very, very important points.
Nice to see you.
Thank you. Me too.
Luigi, could you make a comment about the ongoing trial to compare between balloon dilatation and bougie dilatation you are directing all together with Renato?
We as you know, we prefer bougie, and I don't know what will come from the international survey. Probably the most I think that the major part of the people will describe balloon dilations, but because many gastroenterologists suppose that is a safer strategy, but really I don't agree about this. I prefer, we use balloon dilations only in patients with esophageal stricture in epidermolysis bullosa. And sometimes we perform the first dilations in very, very difficult anastomotic strictures with a 6 or 8 millimeters biliary balloon. But generally we prefer to use a Savary.
Yes, just to tell the audience, there's an ongoing trial comparing between those techniques, and there are some centers from Latin America who are recruiting patients these days. So we will wait for the results. It is, of course, it's an observational study. It's not so easy to design a randomized trial comparing the two techniques, because usually in most of the centers they have more experience with one technique than the other, and it's not possible to compare in a prospective way.
Yes. It is a prospective study, but not randomized in the two techniques.
Yes.
Pablo, can I make a question? Hello, Luigi. It's a pleasure to have you here.
Hello.
Luigi?
Yes. Hi, Juan. How are you?
Hi. I'm fine, thank you. It's a pleasure to have you here. Thank you. I wonder, why do you prefer to use the bougies instead of the balloons? What are the main differences?
Between balloon and bougie?
Yes. Yes.
We as I told before, we prefer the savary, the bougie, because we can manage with our single experience how we can push the savary. Otherwise, with the balloon, we can have only the interface of a manometer, and it's mandatory, in my experience, the use of X-ray to evaluate the complete dilations, avoiding the hourglass picture that sometimes you can see in the during the dilations. And so if you don't remove this hourglass with a full balloon inflation, we hope to perform 9 millimeters dilations, otherwise it's only 7 millimeters.
Thank you.
Okay.
Hello. Hola.
Yes,
Maurice. Can I ask?
Yes.
Hello, Luigi. I'm Daniel Liberto. It's a pleasure for me to see you. In this case, my question is about your stent. In this kind of patient, why you use this stent, Luigi?
In our experience, we plan to insert a dynamic stent only after at least 5 dilations, because generally in the major part of the patients can resolve the problem with little numbers of dilations. But it's very, very important before to insert a stent to rule out vascular malformation that can happen frequently in patients with esophageal atresia, overall the retroesophageal subclavian artery, because this is a clear and strict contraindication to the use of a stent, not only the dynamic stent, also the metal stent. We observed, we published a paper with a group of Montreal some years ago, and they observed 2 patients that died for a massive bleeding after the insertion of a metal stent for esophagoarterial fistula.
Thank you, Luigi.
Thank you.
You're welcome.
To the people, if you see my other presentation, I always try to send a message of co-working or multidisciplinary approach of this difficult patient. So Ignacio, can you put the last diapos, please? we have 3 minutes more, so I can take 1 minute to show you these numbers, because we acquired modern norms and rules of ESPGAN and NASPGAN. So in our service, before 2012 and then posterior to 2014, we reviewed similar number of patients. And before 2012, as I show you, 100% have study contrast, but only 60% of the patients have an study of endoscopy or GI endoscopy or pH-metry and impedantiometry, and only 42 patients have a scintigraphy, like a study of follow-up. 50% have an anastomotic stricture in this older series. 1 patient go to Kimura, 19 patients require anti-reflux surgery, and these patients go to the anti-reflux surgery. 2 patients develop transitory dysphagia. 3 patients go to replacement surgery, and 4 patients death with another causes, not the esophageal atresia. But we start with the rules of the ESPGAN and NASPGAN around 2014, if I don't wrong. And we know the difference to work together with other specialists. And it's something like I like to transmit all of you. In this case, we work with the GI, we work with the imagenologist, with the therapist. In this concept, we have a different follow-up about around or after 2014. 100% have a contrast study, 81% have a pH-metry and impedantiometry, 90% have a GI endoscopy, 70% have a scintigraphy, and we introduced the laryngotracheal bronchoscopy in 88% of the patients with esophageal atresia. I want to remark that here is 6 patients, 22 was referred with a stone burn at the hospital. The global anastomotic structure was 74 patients. The median of dilation was 3. We go to 1 and 6 dilation, but 1 patient referred to us with 17 dilations. And before the 17 dilation, the patient was referred out for hospital. Only 4 patients require anti-reflux surgery. It's a result of multidisciplinary approach, but 4 patients require a replacement surgery. So I show you this diapo because when we work together, we improve the follow-up of this patient. I would like to Dr. Luigi Dall'Oglio say last message of this kind of patient around the world.
Thank you. I think that you underlined the most important aspect of the treatment of these patients. I would like to underline, first of all, the training. It's very, very important to treat these patients after a good training. Second, in our experience, never make dilations, an esophageal dilation, without a guide wire. The guide wire is what can change a dilation from a drama to a safe procedure in our experience. And don't hesitate to use X-ray control during the dilation. And also if you suspect a leak that can happen, because we have to dilate it, not only to pass something into the esophagus. We have to dilate the strictures, and so the leak can happen. It's important to make a correct and quick diagnosis. And the opportunity to have the X-ray in the endoscopic suite, and so to inject directly from the endoscope the hydrosoluble contrast medium can allow to make a correct diagnosis of the stricture. And then you can start with the treatment as you like, obviously, but you can start a quick treatment. And then the last one is every patient is different than the other. Every stricture is different than the others. And every treatment must to be personalized to every patient, because also there are problems not only of the stricture, but sometimes logistical problem of the family. And so we can adapt our strategy to many different aspects. And the last one is wait for surgery. Make a stabilization of, wait for the stabilization of the stricture before to plan stricture resection or more an esophageal substitution, because sometimes can happen something that we can call a miracle, but sometimes we observe strictures that we said before, this is lost, we have to make surgery. Otherwise, after a few weeks, we can observe an improvement of the situation.
Thank you. Thank you very much of your participation. Thank you, everybody, to connect with us so early in the morning. Thank Dr. Luigi, great, huge of the distance. And thank you very much to all of you.
Thank you very much to all of you, all of my dear friends in Buenos Aires and Argentina. It's a very, very good opportunity to see you, even if through this electronic view, but you are. I am very happy for this opportunity. Thank you very much.
Thank you, Luigi.
Thank you.
Bye-bye. Bye.
Bye.
Thank you.
Yes.
Bye.
Gracias.